Welcome to the deep dive. We've got this stack of notes here today, MSRA revision notes,
hmm
actually. And we're zeroing in on a really specific topic, recurrent miscarriage.
Yeah, it's a tough one. And our goal, really, for you listening, is to kind of wade through these notes with us.
Exactly.
Pull out the absolute must-knows. Think of it like the high-yield summary, you
Yeah.
know? Everything these notes say about recurrent miscarriage, structured so it hopefully sticks.
Yeah, make it make sense, make it memorable.
Yeah.
We're aiming to cut through the detail and get straight to what you need, whether you're actually revising or just want to understand this condition a bit better.
Okay, let's do it.
So let's start right at the beginning, the definition. What do these notes actually say recurrent miscarriage is?
Right. The core definition here is 3 or more consecutive pregnancy losses.
Consecutive, okay.
Yeah, consecutive. And that's before 24 weeks of gestation. That 3 or more consecutive losses before 24 weeks, that's the key phrase.
Got it. 3+ consecutive pre-24 weeks. How common is this then? What's the epidemiology picture look like in these notes?
Well, they state it affects around 1% of women.
1%.
Yeah. And if you look at couples trying to conceive here in the UK, the notes cite about 1–2%. And it does say this figure goes up with maternal age.
Right. Age is often a factor.
It is. But that 1% figure for the recurrent cases, it's significantly higher than you'd just expect by chance.
Ah, so it suggests there's usually an underlying reason, not just like random bad luck repeated.
Exactly, that's the implication. The notes also give some context. The overall miscarriage rate is much higher. They say about 12–24% of recognized pregnancies.
Okay.
But the key thing is, once someone's had 3 consecutive losses, these notes highlight the risk of another miscarriage jumps quite a bit, to about 40%.
40% risk after 3. Wow. That really underscores why it's such a big deal clinically.
It does. And something else the notes point out, it can happen even if a couple has had a successful pregnancy before.
Oh, really?
Yeah, and sometimes, even after all the tests, no specific cause is actually found.
So you might get the diagnosis, but not always the why, which I suppose brings us right to that question.
Yeah.
What are the potential whys? What do the notes list as causes and risk factors?
Okay, so the notes list quite a few things, and honestly, there's a lot of overlap between what they call a cause and a risk factor.
Right. Makes sense.
We can sort of group them based on what's here.
Okay, let's break it down then.
So first up, genetic abnormalities, big category. The notes mention parental chromosomal issues, things like balanced translocations.
That's translocations.
Yeah, they say these are found in about 2–5% of couples who experience recurrent miscarriage.
So an issue with the parent's actual chromosomes.
Yeah.
Okay. What else?
Then there are uterine abnormalities, structural problems with the uterus itself.
Like the shape of it?
Exactly. They list things like an arcuate uterus or a septate uterus. Says these are found in roughly 10–25% of cases, so quite common.
Yeah, a physical issue potentially stopping the pregnancy from developing properly.
Right. Then you've got hormonal imbalances, endocrine disorders like PCOS, polycystic ovary syndrome, and also poorly controlled diabetes. These are specifically named as risk factors.
Okay, things disrupting the hormonal environment needed for pregnancy.
Precisely. Next category is autoimmune disorders. And the notes really flag Antiphospholipid syndrome, APS.
APS, okay.
Yeah, this one's key because, as the notes stress, it's treatable.
Ah, treatable. That's a crucial word here.
Definitely. And they say it's found in about 15% of women with recurrent miscarriage.
15%.
Significant.
Very. Then there are thrombophilic disorders, basically issues with blood clotting.
Clotting problems.
Yeah, including inherited types like protein C or protein S deficiency, things like that.
Right. Potentially affecting blood flow maybe to the placenta.
That seems to be the concern, yeah.
Yeah.
The notes also mention infections. They specifically link bacterial vaginosis, BV, with a higher risk of second trimester miscarriage.
Okay, and an infection link, especially for later losses. And preterm birth, too, actually. Then there are lifestyle factors. The notes are quite explicit here.
Things people might have more influence over.
Yes. Smoking, excessive alcohol consumption, and obesity, all listed as significant risk factors.
Okay. So genetics, uterine shape, hormones, immune system stuff like APS, blood clotting, certain infections, and lifestyle. So quite a range of possibilities according to these notes.
It really is. They also briefly touch on other immune factors like natural killer cells, and they reiterate the parental chromosome issue as both a cause and risk factor.
Right. So we have this list of potential whys. The pathophysiology section in these notes, though, seems pretty short. How do they explain how these factors actually, lead to the miscarriage?
Yeah, it is brief. It mostly just circles back to the causes. It does things like genetic problems, either in the parents or the fetus itself,
Hmm.
or the uterine structural problems, or the hormonal imbalances. They basically interfere with the pregnancy developing properly or being maintained.
So they stop it implanting, right? Or growing, or
Yep.
getting the support it needs.
Pretty much. It's the mechanism linking the why to the what happens.
Understood. Okay, shifting gears a bit. Clinically, how does someone typically present? What do the notes say about clinical features?
Well, the absolute key thing, unsurprisingly, is the history.
Right, the 3 losses.
Exactly. 3 or more consecutive losses before 24 weeks. That history is the main presentation. When an actual miscarriage episode happens, the symptoms described are basically the same as for a one-off sporadic miscarriage.
So bleeding, pain.
Yeah, vaginal bleeding, abdominal pain, maybe passing fetal tissue,
Hmm.
the usual, sadly.
Okay, so the pattern is the main diagnostic clue. Given the symptoms can overlap, what else might be going on? What are the differential diagnoses the notes say to consider?
Good question. The notes list a few crucial ones to rule out, things like ectopic pregnancy,
Right, outside the uterus.
molar pregnancy,
Okay,
and cervical insufficiency or weakness. These can all cause pregnancy loss or complications that might look similar initially but need, totally different management.
so vital to check for those other conditions first.
Absolutely. Make sure you're actually dealing with recurrent miscarriage, or if it's one of these other things.
Okay, so patient presents with a history. You're thinking recurrent miscarriage, keeping the differentials in mind. What investigations do these notes say are needed? This is where it gets really practical, I guess.
Yeah, this is the workup. The notes detail several key tests. Karyotyping is important, checking the chromosomes,
Of who?
both parents, and also, importantly, testing the products of conception, the tissue from the miscarriage itself.
Ah, testing the POC.
Yes. And the notes are specific. They recommend POC testing after the third miscarriage.
After the third one. Okay.
And then if that test finds an unbalanced structural chromosomal abnormality, that's when you do the parental karyotyping.
Okay, so there's an order. Test the tissue from the third loss first, and that guides whether you test the parent's chromosomes. That's a really specific pathway from these notes.
It is. Very clear step. They also include assessing hormonal levels and checking the uterus structure.
Right, the structural causes.
Yeah, using pelvic ultrasound initially and maybe hysterosalpingography or HSG. And if those suggest an anomaly, then maybe a hysteroscopy or laparoscopy actually looking inside.
Makes sense, visualizing the uterus if structure is a concern.
It does. Now, the notes are also very specific about screening for those autoimmune and thrombophilic disorders we mentioned.
APS and the clotting stuff.
Right. So antiphospholipid antibody screening that's recommended for women with recurrent first trimester miscarriages or if they've had any second trimester loss.
Okay, so APS screening for recurrent early losses or any later loss, that links back to it being treatable, I guess. Key point.
Definitely a key point. Then for the inherited thrombophilia screening, the blood clotting disorders you're born with,
Yeah.
the notes state this should be done specifically in women who've had second trimester miscarriages.
Ah, okay. So the timing of the loss guides the clotting tests. Inherited thrombophilia screening specifically for second trimester losses. That's a subtle but important distinction the notes are making.
It is a very important detail for revision, I'd say. Pelvic ultrasound, as we mentioned, is also recommended for checking uterine anatomy in either recurrent first trimester or any second trimester loss scenarios.
Right.
And if there's suspicion of cervical weakness, particularly if the history involves second trimester losses, they mention considering serial ultrasound scans to monitor the cervix length.
Checking the cervix if later losses are the pattern. Ties back to cervical insufficiency being a differential. Okay.
Now, probably one of the most high-yield bits of information from the investigation section of these notes, especially for exams, is what is not routinely recommended.
Ah, yes. The don't routinely do this list. Always useful. What's on it?
Okay, the notes explicitly say routine screening for diabetes.
Even though uncontrolled diabetes was a risk factor.
Yeah, interesting, isn't it? Routine screening isn't recommended. Same for general inherited coagulopathies. They distinguish this from the targeted thrombophilia screen for second trimester loss. Also, thyroid disease screening, serum prolactin levels, or TOR-CH syndrome infections. None of these are recommended for routine workup, according to these notes.
Wow. That's a pretty significant list of common tests. Diabetes, thyroid, prolactin, TOR-CH, even some general clotting tests that are not considered routine here. Why would that be, based on the notes, do they say?
They don't spell out the why explicitly, but you can infer. It likely means that for recurrent miscarriage specifically, widespread screening for these hasn't shown strong evidence of consistently finding treatable causes that actually improve outcomes, compared to focusing on the things they do recommend, like APS or checking the uterus.
Fascinating. Focus on the higher yield investigations where treatment might make a difference.
Okay.
So, you do the recommended test, you either find a cause or you don't. What then? What does the management section say?
Right, management. It starts with the general advice, identify and address any underlying cause you find.
Makes sense.
So that could mean genetic counseling, maybe hormone treatments, surgery for uterine issues, or immunosuppressants for something like APS. It's all tailored.
Tailored to the diagnosis. Got it.
Exactly. The notes also really emphasize providing emotional support for couples.
Which must be huge.
Absolutely massive given the emotional toll. And they mention close monitoring in future pregnancies. Plus, there's a really important reassuring point here.
Oh, good. What is it?
These notes state there's actually a high probability of a successful outcome for couples, even after multiple losses.
That's so important for people to hear.
It really is. And they add that things like frequent antenatal visits and ultrasounds in the next pregnancy might help improve outcomes, perhaps through reassurance or early detection of issues.
Okay. That supportive care and hopeful outlook is key. What about specific medical treatments? What pharmacological options do the notes discuss?
They cover several. Heparin combined with low-dose aspirin gets a mention. Specifically, it says this improves the live birth rate to 70%, but only in primary APS patients.
Ah, okay. So only if APS is the confirmed cause. That combo is effective according to these notes.
Yes, for primary APS. But then contrast that with low molecular weight heparin, LMWH.
Okay.
The notes explicitly state that LMWH shows no reduction in miscarriage risk for women with inherited thrombophilia.
Whoa, okay. That's a really critical distinction the notes are drawing.
Nah.
Heparin plus aspirin for APS supported, LMWH for inherited thrombophilia, not supported for reducing miscarriage risk here. That's a major takeaway on the evidence presented.
Absolutely. A crucial point to remember. Metformin is mentioned next.
For PCOS.
Yes. The notes say there is some evidence it might reduce miscarriage rates in women with PCOS, but they immediately add that the data is contradictory.
Ah, mixed signals.
Yeah, and importantly, they state that ARCIA guidelines referenced in these notes do not currently recommend using metformin in pregnancy for this purpose.
Okay, so mixed evidence and currently not recommended by ARCOG per these notes. Clear guidance there. What about progesterone?
Progesterone is discussed too. They reference the PROMISE study. It found progesterone didn't delay the timing of a miscarriage if it was going to happen. But interestingly, over 60% of women in that study had live births anyway, whether they got progesterone or placebo.
So high background success rate.
Seems so. They also mention a Cochrane review that suggested a potential benefit for progesterone, but specifically for unexplained recurrent miscarriages.
Okay, so the progesterone story is a bit muddy in these notes too. No impact on timing in one big study. Maybe some benefit for unexplained cases, according to a review. Nuanced.
Very nuanced. HCC, human chorionic gonadotrophin, is also listed, but the notes say the evidence is equivocal, and actually the higher quality evidence indicates no benefit.
Right, so notes say no benefit for HCG based on the better studies.
Then there's immunotherapy, things like maternal cell immunization, sometimes used for unexplained recurrent miscarriage.
Sure.
The notes' conclusion on this is pretty clear. No significant benefit over placebo in improving live birth rates.
Okay, another potential treatment listed here without strong supporting evidence for benefit. So let's quickly recap that treatment evidence summary from the notes. Heparin aspirin for primary APS, yes. LMWH for inherited thrombophilia, no benefit shown for miscarriage risk. Metformin in PCOS, mixed evidence, not currently recommended. Progesterone, mixed findings, maybe some benefit for unexplained cases. HCG, no benefit. Immunotherapy for unexplained. No benefit shown. That's a really helpful, focused summary based purely on what these notes present.
Yeah, it gives you very specific pointers based on the evidence they've included. Now, shifting to surgical management, cervical circlagers is discussed.
The stitch in the cervix.
Exactly. Described as a prophylactic stitch, usually put in around 12-14 weeks gestation if cervical incompetence or weakness is suspected.
Right, to help support the pregnancy.
Yes. But the notes also mention potential downsides, like possibly overdiagnosing the weakness and the risk that the stitch procedure itself could stimulate contractions.
Okay, so not without risks. Who gets offered it then?
According to these notes, it's offered to women with a specific history. Second trimester miscarriages thought to be due to cervical factors, and importantly, only if they are carrying a singleton pregnancy, one baby.
Got it. History of later losses due to the cervix, and just one baby. Very specific criteria mentioned.
Exactly. They also briefly mention preconceptual abdominal circlage done before pregnancy. Notes say it's being used more, and there's evidence it might be beneficial without causing harm.
Okay, another surgical option noted. So that seems to cover the main management strategies listed here.
It does. It spans that general support, the investigations trying to find a cause, and then these specific treatments, along with the evidence for or against them, as presented in these particular notes.
So what's the overall picture then? The prognosis. What do the notes say about the chances long term?
Well, the notes state that the prognosis really varies a lot. Depends heavily on the underlying cause if one is found. If you find a specific cause, like APS, and treat it, that may improve the chances. But the notes are careful to add that the risk of having another miscarriage might still be there.
So finding and treating something helps, but it's not necessarily a magic bullet, and it really depends on what the cause is.
Precisely. It's very individualized.
And finally, complications. Beyond the awful physical experience of loss itself, what other complications do the notes highlight?
They really emphasize the emotional and psychological impact.
Yeah.
That's listed as a major complication. The stress, the grief, the anxiety that comes with repeated losses. It can also obviously lead to fertility challenges down the line, difficulties achieving that successful pregnancy. And they also mention potential complications related to treating whatever underlying cause is found.
Right, so the impact goes way beyond the physical, affecting mental health, future plans. That's so important to remember alongside all the medical details.
It's absolutely central to supporting couples going through this.
Okay, well, we've really tried to dig into these MSRA revision notes on recurrent miscarriage. We've gone through the definition, the numbers, the potential causes, how patients might present, what else it could be, the key investigations, especially that list of what not to do routinely. The evidence, as presented here for various treatments, the overall prognosis, and the wider complications.
Yeah, hopefully we've given you a kind of high-yield walkthrough of this specific material, really highlighting the points these notes emphasize for revision.
Definitely. Which brings us to our final provocative thought for you, drawing on what we've just discussed from these notes. So, these notes tell us a significant chunk of recurrent miscarriages remain unexplained.
Yeah, unexplained is a common outcome.
And they also show us that for some causes we can identify, like inherited thrombophilia, and for those unexplained cases treated with things like immunotherapy or sometimes progesterone, the evidence presented here shows pretty limited or conflicting benefits.
Right, the evidence isn't always strong.
So, given that combination, lots of unexplained cases and limited evidence for treating some explained or unexplained ones, what does that specific picture painted by these notes highlight about the current, maybe limits of our medical understanding in this area? And flowing from that, how much does it underscore the importance of really focusing our efforts on identifying and properly managing the conditions like antiphospholipid syndrome, where these notes do point towards effective evidence-based treatments?
It's definitely thought about resource allocation, isn't it? Focusing on where the evidence, as presented here, shows we can make the biggest difference, while acknowledging there's still a lot we don't fully understand or can't yet effectively treat.
Something to mull over. We really hope this deep dive into your recurrent miscarriage notes has been useful for your revision. Do revisit these points, the definitions, the specific causes, those investigation lists, the treatment evidence nuances. Making those connections is key.
Absolutely. Getting those specifics down is what it's all about for revision.
Okay, that wraps up this deep dive. Thanks so much for joining us.
My pleasure.
And remember, for more revision materials like this, you can head over to PassThemCentury.com and also check out FreemCentury.com.
Great resources.
We'll catch you on the next deep dive.